Kawasaki disease (KD) is an acute, self-limited, febrile illness of childhood, characterized by systemic inflammation of the medium-sized arteries, most notably the coronary arteries, and in multiple organs and tissues. KD leads to the development of coronary artery aneurysms in up to 25% of untreated cases and is now the leading cause of acquired heart disease in children in the developed world. What are the diagnostic criteria for KD? Fever or a history of fever is almost always present in patients with KD. Exceptions include very young infants in whom fever may be low-grade or unrecognized, or patients diagnosed late in the illness, and whose parents did not recognize fever during the acute phase. Fever is a necessary component in the clinical diagnostic criteria for KD. It is usually high-grade, greater than 38.5 degrees Celsius, unresponsive to antibiotics, poorly responsive to antipyretics, and lasts an average of 1 to 3 weeks. The diagnostic criteria for KD are: fever for greater than 5 consecutive days, with 4 of the following 5 criteria. 1. Conjunctivitis greater than 90%, bilateral bulbar non-exudative conjunctivitis, often with limbic sparing. 2. Oral changes 90%, erythema, fissuring, cracking, or bleeding of lips, diffuse oropharyngeal erythema without exudate, and/or strawberry tongue. 3. Cervical lymphadenopathy 25%-70%, least common finding, 1 or more enlarged, greater than 1.5 centimeters, nodes in the anterior cervical triangle, usually unilateral and sometimes painful, can be confused with bacterial cervical lymphadenitis. 4. Rash 70%-90%, erythematous rash, usually a diffuse maculopapular eruption, erythroderma, erythema. Multiform like urticarial, scarlatiniform, and micropustular eruptions are also seen. Bullous, vesicular, and petechial rashes not seen in KD patients. Rash typically involves the trunk and extremities, and there may be accentuation in the groin, 50%. 5. Extremity changes, 60%-85%, last manifestation to occur, erythema of palms and soles and firm, sometimes painful edema of the hands and feet. Desquamation of the fingers and toes begins in the periungual area, usually 2 to 3 weeks after fever onset. Desquamation may also involve the palms and soles. A history of any of the clinical criteria listed above count as diagnostic criteria even if not present at the time the diagnosis is considered. What epidemiologic facts are known about KD? KD affects predominantly, but not exclusively, young children. Majority, 75%, of children are aged less than 5 years. Males greater than females 1.5, 1. The highest relative risk, 17 times, is in Asian children, especially those with Japanese ancestry. The incidence is approximately 2% in siblings and 13% in identical twins. Recurrence rate is 3%. It is most common in winter and early spring in North America. Local outbreaks and epidemics of KD have been reported. Most common vasculitis of childhood, previously called infantile polyarteritis nodosa, rarely occurs in adults. Freyson J.B. et al. Autoimmune Rev 15. 242, 2016, with or without coexistent human immunodeficiency virus. Five. What other clinical symptoms or conditions may be seen in the acute phase of the illness? Musculoskeletal. Arthritis or arthralgia may involve large and/or small joints, 7.5%-25%. Usually short-lived. Synovial fluid WBC count can be greater than 100,000 m3. Cardiovascular. Myocarditis, pericarditis, shock, aneurysms of medium-sized arteries, 20%-25%, aortic root enlargement. Ocular. Anterior uveitis, 80%. Respiratory. Cough 30%, hoarseness. Gastrointestinal. Vomiting and diarrhea with abdominal pain, 40%-60%, pancreatitis. Hepatitis, 30%-40%, gallbladder hydrops. Genitourinary. Urethritis, sterile pyuria. Nervous system. Extreme irritability, 50%, aseptic meningitis. Facial nerve palsy. Sensory neural hearing loss, less than 1%. Skin. Inflammation at previous BCG immunization site, characteristic. Others. Macrophage activation syndrome, MAS. Is there a diagnostic laboratory test for KD? No, there is no diagnostic laboratory test for KD. KD remains a clinical diagnosis. Laboratory tests show the findings of acute inflammation including elevated ESR, CRP, leukocytes, and platelet count. The platelet count typically rises after the 7th day of illness and may exceed 106. 3. Any patient who develops thrombocytopenia, elevated liver-associated enzymes, high triglycerides, and extremely elevated ferritin levels should be evaluated for MAS. Recent data suggest that 80% of children with KD who ultimately develop coronary artery lesions, Z-score is greater than or equal to 2 to less than 2.5 equals dilation. Z-score is greater than or equal to 2.5 equals aneurysm, will have them present at the time of diagnosis. Therefore, an echo showing coronary artery lesions would be useful in establishing the diagnosis of KD. In general, an abnormal echo can be used to establish the diagnosis of KD, but a normal echo cannot be used to rule out a diagnosis of KD. A Z-score of greater than 2.5 in the left anterior descending or right coronary artery has a very high specificity for the diagnosis of KD but lacks sensitivity. Similarly, without a Z-score of greater than 2.5, an echo is also considered positive for a diagnosis of KD if 3 or more of the following are met. Z-score of the left anterior descending or right coronary artery of 2 to 2.5, decreased left ventricular function, mitral regurgitation, or pericardial effusion. What other diseases need to be considered in the differential diagnosis of KD? Staphylococcal and streptococcal toxin-mediated disease, scarlet fever, toxic shock, viral infections, measles, adenovirus, enterovirus, Epstein-Barr virus, drug hypersensitivity reactions, Stevens-Johnson syndrome, rheumatological, systemic onset juvenile idiopathic arthritis, other, with appropriate epidemiologic risk factors, leptospirosis, rickettsial infections, mercury intoxication. What causes KD? The cause of KD is unknown. Current data suggest that the disease results from an immune response to a classic antigen in genetically susceptible individuals. Numerous infectious pathogens have been proposed as etiologic agents but all have been subsequently disproven. The two most active lines of investigation suggest infection with a novel RNA virus via the respiratory tract or transport of an agent in tropospheric winds that initiates the immunologic cascade of KD when inhaled. Epidemiology, genome-wide association studies, and linkage analysis have provided evidence that there is genetic susceptibility to KD and disease outcomes. In particular, the genes Fc gamma R2A, caspase 3, human leukocyte antigen class II, B-cell lymphoid kinase, inositol 1, 4, 5-trisphosphate kinase C, and CD40 have been implicated. Is there an effective treatment for KD? Intravenous immune globulin, IVIG, at a dose of 2 grams per kilogram given over 10 to 12 hours is the treatment of choice for acute KD. This is more effective in preventing persistent coronary artery aneurysms if given within the first 10 days after the disease onset. IVIG is given in conjunction with high-dose aspirin, 30 to 50 or 80 to 100 mg per kilogram per day in 4 divided doses. Once the fever has resolved, the dose of aspirin is decreased to a single oral dose of 3 to 5 mg kilogram per day for its antiplatelet effect. In those who do not develop coronary artery abnormalities, the aspirin can be discontinued 6 weeks after treatment and when the ESR, CRP, and platelet counts have normalized. Are there patients with KD who might benefit from more aggressive initial therapy? Numerous studies have shown that 10%–35% of patients with KD fail to respond or develop recrudescent fever. These patients are characterized as IVIG resistant and are at high risk for developing coronary artery aneurysms. They, therefore, require additional therapy to interrupt the inflammatory process. There have been many efforts to prospectively identify KD patients who have a high likelihood of being IVIG resistant or who will develop coronary artery aneurysms in order to treat these patients more aggressively and decrease the incidence of coronary artery lesions. Prior studies from Japan have resulted in successful scoring systems including the Agami, Sano, and Kobayashi scores to predict IVIG resistance. Intensified therapy with prednisolone and IVIG in these high-risk patients improved coronary artery outcomes in the study populations. Unfortunately, these scoring systems have low sensitivity in heterogeneous U.S. populations, and efforts to identify high-risk, IVIG-resistant patients in North American cohorts have been unsuccessful. Although rigorous, prospectively controlled studies are lacking, some U.S. centers have taken the approach of targeting KD patients with intensified therapy who present with coronary artery lesions or who have epidemiologic risk factors such as young age. Intensified regimens include the addition of infliximab or steroids to standard therapy of IVIG and aspirin. What is the treatment for patients with KD who are resistant to IVIG therapy? IVIG resistance is defined as fever that occurs from 36 hours to 7 days after the end of the IVIG infusion. Between 10% and 35% of patients with KD are IVIG resistant. There are no current consensus guidelines regarding what is the optimal therapy for patients who are IVIG resistant. Options for therapy include administration of a second dose of IVIG, 2 grams per kilogram, infliximab, 5 mg per kilogram, or high-dose pulse steroids, 20 to 30 mg per kilogram intravenously for 3 days with or without a subsequent course and taper of oral prednisone. For patients with refractory KD who fail to respond to a second course of IVIG, infliximab, and/or steroids, other therapies to consider include anakinra, cyclosporin, or plasma exchange. What is the appropriate follow-up for patients with KD after discharge from the hospital? Patients without coronary artery lesions should be seen by a pediatric cardiologist and repeat echoes obtained approximately 1 to 2 weeks and 6 weeks after discharge from the hospital. If echoes remain normal, patients may discontinue thromboprophylaxis with aspirin. Patients should also be seen at 1-year follow-up for repeat echo and lipid profile testing. Some experts recommend follow-up every 5 years thereafter with exercise stress testing and lipid profile testing. 4. Patients with coronary artery lesions. Much closer and more aggressive follow-up with cardiology is indicated. Thromboprophylaxis with aspirin, clopidogrel, warfarin, and/or low molecular heparin is decided based upon the size and location of the coronary artery lesions as well as the presence or absence of thrombosis. Medical therapies with beta blockers, angiotensin-converting enzyme inhibitors, and statins may also need to be considered. What is the long-term outcome of patients with a history of KD? The majority of coronary artery lesions will normalize in size by 1 year after diagnosis. Despite normalization of internal luminal size, however, the arterial wall architecture and function may remain abnormal in some patients, which could lead to stenosis and occlusion over long periods of time. Decade long-term follow-up on KD patients is currently lacking. Patients with persistent lesions are at continued high risk for thrombosis and myocardial infarctions. What if a patient does not have enough clinical criteria to meet the clinical case definition of KD, but I am still worried my patient might have this disease? Does incomplete KD exist? Yes, incomplete KD does exist. The clinical case definition of KD does not identify all children with the disease. Up to 10%–25% of patients with KD do not meet the full clinical criteria of KD at diagnosis. This is particularly true for infants aged less than 6 months who may present with only fever. Patients diagnosed with KD whose signs and symptoms do not fulfill the clinical case definition are diagnosed with incomplete KD. The American Heart Association has published an algorithm for the evaluation of children with suspected incomplete KD. Using this algorithm, children with fever for greater than 5 days and at least 2 clinical diagnostic criteria, or infants with fever for greater than 7 days without an alternative diagnosis, should have inflammatory markers, C-reactive protein, CRP, and erythrocyte sedimentation rate, ESR, obtained. If the CRP greater than 3.0 mg per deciliter or ESR greater than 40 mm per hour, then other laboratory studies should be performed to look for abnormalities that commonly occur in KD: anemia for age, white blood cell WBC count greater than 15,000 M3, platelets greater than 450,000 M3, albumin less than 3 grams per deciliter, elevated alanine aminotransferase, or urine WBC greater than 10 HPF. Additionally, an echocardiogram (echo) should be obtained. If 3 or more of the other laboratory studies abnormalities are identified or the echo has positive findings, then a diagnosis of KD should be made and the patient should be treated.